So that's why we choose amikacin, not gentamicin, based on this.
In Egypt, no study in Egypt?
There is some studies. This actually, Egypt was one part. I might have a. I'm not sure about the distribution in Egypt, but there was a study. There was a study from the Middle East. I maybe remove this slide. There was a study in 12 countries from the Middle East in early onset sepsis, and it was still gram-positive. But this was not just from Egypt. Egypt was one of the countries. There is one study in Saudi Arabia also. I might come. Actually, I removed some slides, but there was one study in Saudi Arabia done in one of the hospitals, and it still was for early onset sepsis, full-term babies, and was still group-based. But still, you have to do your survey, because changing the location, even in the same country, you might have different organisms. Okay, so looking to the epidemiology of the sepsis now, so the overall incidence of neonatal sepsis range from 1 to 5 cases per year, and it's always per 1,000 live births. Again, this is a USA. This is a USA data. Might be different in here, might be different in Egypt. The estimated incidence, of course, it is lower in term infant with a reported rate 1 to 2 cases per 1,000 live births. The incidence of postpartum prophylaxis predisposed to worse neurodevelopmental outcome. So that's why it is now going to be very selective on which woman would receive antepartum prophylaxis for antibiotics. That's why they want to make it, the guidelines are strict and more strict and more strict. So not to be liberal with antibiotics, now they receive CT and lower the neurodevelopmental outcome. So what's increased the risk of infection? This is talking about late onset sepsis, but actually in sepsis in general. Obviously, the lower the weight and the lower the gestational age, the more chances and the more risk for infection. If you are doing anything invasive, so everybody we know that we have protective mechanisms to protect us. You have your skin, your mucous membrane, you have the mucus covering the intestine. So anything that breaches this, then it can increase the risk for infection. So if you're doing any invasive intervention, you break the skin and do intravenous catheters, or if you're giving parenteral nutrition, and we know that the parenteral nutrition solution are very good medium for bacteria. It can be like this. Or the baby has other comorbidities, like he has patent ductus arteriosus, or he has other disease like necrotizing enterocolitis and or chronic laminitis. This is very important. This is more than 5 days. So any baby that receives more than 5 days and of early to treat early onset sepsis, you're predisposing for late onset sepsis, and also can predispose him for necrotizing enterocolitis. The clinical presentation of how they present this low, very low birth weight infant with sepsis differ, but most commonly they present with apnea, so respiratory symptoms. 55% in one study showed they present with apnea. They can present, of course, with feeding intolerance, abdominal distension, and they can present with guaiac positive stools. They pass blood in their stools, or increased respiratory, beneath increased respiratory support, 29%. And finally, they can have, of course, lethargy, hypotonia, and also they can have increased risk of death.
No fever? No fever?
Babies usually don't present with fever. Most of the babies that they have sepsis, they will present with hypothermia. Some will present with fever, but that's not really the common scenario. So the common scenario, when here we're talking about very low birth weight infant, those babies mainly will present with respiratory symptoms like I said. So
very low birth weight مش هيبقى في incubator. في الغالب في incubator في حضانة.
Most probably will be. But that's not the reason why he will not present with fever.
عملنا ريجوليشن التمبريتشر بتاعته عن طريق الانكيوبيتور يعني حاطين في الانكيوبيتور.
Yes, but what usually you set the incubator at 1 degree. So if you have a fever, you will still discover it because your baby is being fine, stable on that degree for 2-3 days, 4 days, and all of a sudden now you measure his temperature, it's going to be very high or low. So the presence of because the incubator doesn't go up and down.
So fever unlike
most of these babies present with hypothermia. Fever, it is rare, and it's mainly happen in full-term babies, not for, those babies, rarely, they will have a fever. And in our teaching, if you have a baby present with fever, you have to make sure that this baby doesn't have two things: meningitis or herpes infection. That's the two things that you have to think that these babies don't have if they have fever. So blood culture should be collected of course by peripheral vein culture before the beginning of antibiotics, and if positive, it should be repeated during the treatment to evaluate treatment effect. And most of the time, so some organisms we don't repeat the cultures, like bones we don't usually repeat. But if you have a baby who's gram-negative, then you better treat, especially like in a unit like I discussed that scenario in, that in your unit you have a multi-drug resistance bacteria, then you should repeat the antibiotics. Positive blood culture, of course, confirms sepsis, and when the blood culture is negative, the condition is considered as clinical sepsis. We said that. An alarming fact in many neonatal intensive care units, so we do a lot of rule-out sepsis, because all the symptoms and the signs we said, they are not specific. Babies have apnea, babies are lethargic, babies are hypotonic, babies have cyanosis. These are not really specific for sepsis. So we do a lot of sepsis workup. In some units, they found that they might do 11 to 23 rule-out sepsis, and you only have one real sepsis. So we do a lot of sepsis, but there is, until now, we don't have any other ways to do, because we are not sure this baby is septic or not, and we don't have fast tools to say or confirm this baby is septic or not, and you don't have a fast test. The gold standard test will take 2 days to come back. So what can you do? Your baby is acting septic, your culture is still pending. I don't have any other tool to really confirm this baby is septic or not. So you treat a lot of babies to save only one. Okay, should we do urine culture or not? So the recommendation that if the baby is less than 6 days, that the urine culture is not really necessarily as a part of your sepsis workup. If the baby is more than 6 days, then you should do urine culture. CSF, should you do also lumbar puncture? Or meningitis? By the things, nothing is very clear. But there is certain things. The most common thing I said is respiratory and feeding problems. This is maybe I'm not going to do a lumbar puncture, because this is really a common scenario and it's very non-specific. But if we go to the extreme, babies becomes really hypoactive, lethargic, or the babies start to have hemodynamic instability, or you have, but this is really going to be a late sign. So here I will do the lumbar puncture. So it really depends still.
I think there's no great difference between the management of this guy,
there is some. Because you might use antibiotics that are not really good coverage and they don't cross the blood-brain barrier. That's one thing. And the second thing, how long are you going to treat? We'll talk about this. And because in rule-out sepsis and in gram-positive, you might treat for 1 week. But if you have a meningitis, you might treat 2 to 3 weeks. So that's the two things you have to really know why you have whether you have meningitis or not. This is from the paper published 2012 from the American Academy of Pediatrics, and they said some recommendation to do when to do the LP. So if you have a positive blood culture, so once you have a positive blood culture, you ought to do a lumbar puncture. The only organism that we rule out of this guidelines is the Crohn's infection. That's it, because it's very rare to cause meningitis. Coagulase negative staph, they're late on steps. Otherwise, we do. So Staph aureus, we do. Any gram-negative, we do. The second, clinical findings that are highly suggestive of sepsis. Highly suggestive. Not really, like we said, just some apneas and some desaturation and some abdominal distension. When we go to the extreme, hypotonia, lethargy, hemodynamic instability, then you have to. Or laboratory data strongly suggestive sepsis, and we will see we'll say what are the laboratory data there. Or worsening clinical status, why the baby on antibiotics? That has to clinical standard test will stay 48 hours. So what we do in this 40 hours? To guide more information. So now, really to say your baby is septic or not, it's like a vague picture that you are trying to collect some information from here, some information from there, put them together to clarify the picture for you. Your clinical sense is one thing, your culture is, again, gold standard, plus some things we're going to talk about, the CBC. And we ignore the CBC, but the CBC is very informative and can tell you, from the CBC, we can collect some information to tell you your baby has sepsis or not. But the problem that if you are looking for early onset sepsis, the CBC, the best time to get it about sepsis, we advise to repeat the CBC again, either in the second day or after 6 to 12 hours. Okay, what do we look at the CBC? Total white count. So high white count with low white count, then that's one indication for sepsis. The absolute neutrophilic count. So less than 1500, then it's another parameter to make sure that this is sepsis or not. In very low birth weight infant, you maybe use 1000 instead of 1500 for 14 days. This one tool that's ignored, but it's as good as the CRP to look for the IT ratio, the immature to the total neutrophils. Okay? Called the IT ratio. If this number is less than 0.2, means the immature is more than 20% of the total, then this is a good indicator that there is sepsis there. And this is as good, I will show you the number, but it's as good as a CRP. We use the CRP, but nobody looks at this, and nobody calculates this ratio. It's very important. Both are most useful in identifying, and then the platelet count.
دي اللي بنسميها البنديميا دي ولا
اللي هي البنديميا.
البنديميا.
So that you look at the bandemias and the metas and the minus. You add them together, and then you divide them by the total neutrophil.
كان بيقول أكتر من 10%
20%.
indicator 20.
So it should be less than 20%. If it is more than 20%, then that's a risk for them. But not just the bands. Bands, metas, minus. All the immature divided by the total neutrophil.
What about platelets, Dr. Hesham?
Platelets, of course. If the baby has low platelets, that's another indication for sepsis. So we look at the white count, the absolute neutrophilic count, the IT ratio, and the platelets. Other things you might look at, all these things here. Interleukins, 6, 8, 10. Some look to the tumor necrotic factor, alpha, CD64, CRP, and the procalcitonin. The most common use is CRP, but there are actually many other things that you
عندنا
can
اللي
use.
بيستخدم هو السي ار بي في الغالب يعني.
Platelets count, cut point, number.
We use 150,000. Seen a lot of babies proven to have gram-negative sepsis, gram-negative, and they are very sick and sometimes die, but their first CRP is low. So it takes time. So your first CRP might not tell you if this baby is septic or not.
بنستخدمه أكتر في الفولو أب ولو معاه كالشر بيبقى جزء.
Sure, but you're always going to do a culture. But if my CRP will take time to build up, it's not going to help me on day one. See, we're looking to things to help you on day one, this baby is septic or not. So the CRP sometimes takes time, and in my unit, I'm telling you my experience. Babies, their culture will come gram-negative, and you look back to the first CRP done at the time of that you draw the culture, and the CRP is low. Then it takes time. Then it will come up, but it will take time. 24 hours, sometimes. So at the beginning of sepsis, CRP concentration are, if it is more than 1, actually this is considered abnormal. But see, in only 16%, this is from a study, only 16% of the time you will find your CRP, the first CRP, is high. Usually it takes 24 hours to come up. Then you will be 92%. So what should we do? So the recommendation now, just to summarize this part, the recommendation is to do multiple tests. So not depend on one thing. You have to combine things together. So this shows you the sensitivity and specificity of things combined together. The more you combine tests, the higher the number. Here 100%, see if you have 3 tests together. The CD4, the CD64, interleukin 6 or CRP, and here also the procalcitonin with the CRP and interleukin 6. Now you increase the sensitivity. If you don't have this, procalcitonin is as good also by itself as CRP. If you don't have it, so at least to combine the parameters from the CBC plus the CR. This is increase your sensitivity and specificity for when you combine both together, at least. But what other things you can use? Some clinical things they talk about, which they call it the hero score. Do you know the intrauterine fetal traces, right? We talk about monitor the baby's heart rate, intrauterine, and the late deceleration and the variability, and so they did the same, exactly the same thing, but after delivery. So looking at, this is normal. So they in a certain module they put now on the monitor of the baby to pick variability and deceleration. This is what's normal. So baby's usually heart rate, it keeps up and down. It does not stay flatline. Because this is the conflict between the parasympathetic system and the sympathetic system on the rate of the heart. And this is a good healthy sign. When it disappears, so loss of variability, this predicts sepsis or death in the coming 72 hours. So this is an early detection of sepsis or pending death. Loss of variability or deceleration. So it exactly looks like the intrauterine tracing of the heart rate. So how we treat now? So the choice of antibiotic therapy for suspected sepsis should be tailored for the most likely organism with the highest mortality risk with consideration to a local resistant pattern. This is what we said in the beginning of the lecture. Your choice of antibiotics depends on which bacteria you have and what you because I know in Egypt they use, for early sepsis, a lot of units use unison. Am I correct? Am I still using unison or unison and gentamicin? Amikacin. But I'm not sure why the unison was chosen, based on what. But the ampicillin will gram positive also. So the difference between the ampicillin and the unison, the sulbactam, which cover anaerobes. So do you have anaerobes in Egypt?
Yes.
Did you have any culture proven that comes positive for anaerobes? So
انت بتحاول تكبر اقصى حاجه ممكنه.
yes, but you have to give me. I would choose unison if you. The difference between ampicillin and the unison is the anaerobes.
Maybe the quality of the medicine. Yes. Because the manufacturer of ampicillin and sulbactam is high quality companies.
We don't have.
So you don't trust the ampicillin.
Yeah.
Ampicillin is a good source. If ampicillin, sulbactam, unison, it's a good source of manufacture of company.
Okay.
Ampicillin usually came from MOH and usually nothing.
Ah, so that's see. Now look.
For this reason only.
كانك بتديله ميه.
Yeah, so that's why we cannot. I always say this. You cannot take guidelines from states and say I'm going to follow this. No, you have to know your culture. You have to know the bacteria you have. You have to know your sensitivity. So not everything you can apply by.
المستشفيات ممكن ما تلاقيش كرشه. يعني انت ممكن تبقى شغال في
That's another big problem.
ما فيهاش كرشه اساسا.
Another big problem.
Usually we refer for culture private sector or private labs outside the hospital. Usually, most of hospitals no culture.
دكتور أسامة حضرتك تقول حاجة؟
لا هو كان نفس الكلام ده دكتور أسامة.
Yeah, this is really I practiced in Egypt for 4 months. And this was like a surprise for me. So I'm saying let's do.
الكلينيكال باثولوجي مايكروبيولوجيست يعني مش افيلابل قوي في السيكتور الجنرال بتاع الانتظار الصحي. افيلابل في الجامعه عشان في ديبارتمنت.
ممكن ما تلاقيش اصلا كلينيكال باثولوجي في مستشفى مثلا. ممكن ما تلاقيش.
يعني this is not cost effective. يعني قصدي أنا.
Planning, we have no system. We have a problem for the system. Okay, we have to try blind.
Yeah, this makes life a lot more complicated.
يعني شوف even حتى الفيرست انفستيجيشن الاولانيه ممكن التايمنج نفسه نو لاب till tomorrow. اوكي؟
انا
عارف انا
انت مثلا
هو الساينس سمول.
مشكله صعبه جدا للناس اللي بيبقوا اخدوا ماستر جامعه راجل الجامعه متعودين على شغل معين وفجاه يلاقي نفسه في المستشفى ما فيهاش اي فاسيلتيز وشغال على عرض بسيط.
هي المشكله مش الابلكيشن اوف ميديسن عندنا، المشكله في الكوميونيكيشن وفي الريسورسز وفي التيم ورك نفسه. في مشكله كبيره. You can have an NICU with 5 critical babies with no nurses. This shift, nurses absent nurse, and we will call for another nurse.
We need to build a good system.
But I said
Sometimes it's so
academic centers this work can do it.
Yeah.
I could more than it helps.
Yeah, يعني
the practice of medicine in other countries is so easy.
scientific centers is
بس لما ممارسة الطب عندنا دي مش حاجة مش سهلة.
The optimal duration of empiric antibiotics use decreases the development of antibiotic resistance. It prevents unwanted flora. So what we're trying to say here that you have to choose the optimal duration for the antibiotics, empiric antibiotics you're going to use. Because it affects your resistance and it will change the flora. So the antibiotics you're going to use, they're not really differentiate between the organelle you want to kill and the natural flora that actually protective for infection. You're going to kill all bacteria. And once you do this, this increases the risk for infection, as I said. More than 5 days antibiotics will expose for late onset infection and increased neck. Okay. Vancomycin, this is CDC recommendation. And I said, you don't have to follow this. We actually recently we stopped using vancomycin to avoid the vancomycin resistance organism. We have, in our unit, we have a lot of cones. What do you use as a second late onset sepsis? Flux. You use fluoxacillin now, okay? So we don't use fluoxacillin because our cones, zero response to fluoxacillin, zero. Not even a single organism responds to fluoxacillin.
You use fluoxacillin regardless if there is central line or not?
Flux is now we are not using Vanco.
Yes.
Except in very.
جايد انت شغال على
المشكلة انتوا ما عندكوش كالتشر. another point. طيب احنا most of عشان احنا in our unit most of our late onset sepsis is cones. And cones responds to vancomycin. But some units like our unit we have resistance to the vancomycin. Some of our cones bacteria they don't respond to vancomycin. So recently we changed to tawakol. This is a new antibiotics. Tawakol. This is just recently introduced.
حاجة طبعا جديدة عشان الناس برضه نازلة في مصر حاجة أورال.
افازوليد نيمازوليد افازوليد
أفرزوليد حاجة
افازوليد.
That's like less fluoxacillin in our units are not using. Third generation cephalosporins we should not use as empiric antibiotics. This is the worst thing you will do to your unit to use the third generation cephalosporins because it predisposes to multi-drug resistance bacteria. The bacteria that we've discussed before, this third generation cephalosporin predisposed for this bacteria, so we don't actually advise to use any cephalosporin. So how long we treat? 10 days for the proven sepsis. If for cones, usually we use 7 to 10 days. For gram-negative, 2 weeks, and we like to go double antibiotic, double coverage for 1 week, and you should have a negative culture. 1 week double, and then the second week you can continue with only a single coverage, as long as you have a negative culture already. Of course, if you have meningitis, you will give prolonged. It might give 2 to 3.
3 weeks.
Okay, I think we'll stop here. IVIG proven not to work. So there's a lot of studies now in Cochrane review that IVIG does not really work in sepsis, so it's not advisable to treat with IVIG.